Bismillahirrahmanirrahim. We will recognize the definition and classification of seizure, recognize the definition and classification of epilepsy, understand the etiology of seizure, and understand the diagnosis and treatment of epilepsy. 2-year-old boy was brought to the emergency room after experiencing an attack of rhythmic jerking of upper and lower extremities, with his eyes rolling back into his head for approximately 1 minute. Taking his developmental history, we found that he has a normal development. His family history was positive because his sister had experienced a similar attack at the age of 18 months. On examination, we found that the child was normal except for the presence of fever. His temperature was 39 degrees centigrade. There was no signs of meningeal irritation. The patient is healthy, developmentally normal, 2-year-old boy presenting with generalized tonic-clonic seizure that has been provoked by a fever, suggesting that he has a simple febrile seizure. His family history was positive for febrile seizure. What is the differential diagnosis? Any child presenting with seizure in association with fever, we must consider sinus infection, meningitis, encephalitis, or brain abscess in any child presenting with seizure in association with fever, particularly if it is acute seizure. In children presenting with recurrent seizure in association with fever, epilepsy should be considered because some epileptic children may develop the convulsion in association with fever as precipitating factor for the occurrence of seizure. Seizure is a transient occurrence of signs and or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. The signs or symptoms of seizure could be either motor or non-motor, and so seizures could be motor seizures or non-motor seizures. The motor seizures are called convulsion. The seizure could be either provoked or unprovoked. Provoked seizure means it is caused by fever or acute cerebral insult, and we will discuss the causes of acute symptomatic seizures later on. The unprovoked seizures is called epilepsy when it is recurrent. So epilepsy is a recurrent unprovoked seizure. We mean by the recurrence that the child developed 2 or more attacks more than 24 hours apart. And we mean by unprovoked seizure that the seizure is not caused by a fever, it's not febrile seizure, and is not caused by acute brain insult. Seizures could be either focal or generalized. Focal seizure occur when epileptic discharge originates in only one side of the cerebral hemisphere, while generalized seizure is due to generalized epileptic discharge. The focal seizure could be either motor or non-motor, and also generalized seizure could be either motor or non-motor. Causes of seizures. The seizure could be either acute seizures or could be recurrent. The acute seizure is either febrile seizure or acute symptomatic seizure. On the other hand, the recurrent seizure is usually epilepsy, but also febrile seizure may be recurrent. Etiology of acute symptomatic seizure. When a child presents with acute onset of seizure, it could be related to head trauma, either due to birth trauma or head trauma, traumatic brain injury later in life. It could be related to a brain anoxia or hypoxia, either prenatal hypoxia or maybe a severe chest disease that causes hypoxia, or hypercyanotic attacks like in congenital cyanotic heart disease and fallot tetralogy. Also, acute symptomatic seizure could be either related to intracranial infection. Acute seizure may also occur due to metabolic disturbance like hypoglycemia, hypocalcemia, hypomagnesemia, hypo or hypernatremia, alkalosis, and following correction of acidosis. Acute seizure may also occur in children with intracranial hemorrhage. Toxic causes and poisoning may be a cause for acute seizure. Drug poisoning also may be a cause for acute seizure, mainly syophyllin toxicity. Brain tumor usually cause recurrent seizure, but it may present as acute seizure. Cerebrovascular causes of acute seizure is usually due to cerebral embolism or thrombosis causing stroke, and usually it is associated with focal seizure. Febrile convulsions are generalized tonic-clonic seizures that occur due to sudden rise of body temperature, and the cause of fever is due to extracranial infection, not intracranial infection. Convulsions that occur in children with intracranial infection like meningitis or encephalitis are not called febrile seizures. Febrile convulsions are the most common cause of seizure in childhood, with an incidence of 3 to 4%. The age of febrile convulsion usually occur between the age of 9 months and 5 years of age. It is rare, below 6 months, and uncommon after the age of 6 years. The peak age of onset is around 1.5 years. Strong family history of febrile convulsion in sibling and parents suggests a genetic predisposition. Autosomal dominant inheritance is suggested. Types of febrile convulsion. Febrile seizure could be either typical, or it is called simple febrile seizure, or it could be atypical, it's called complex febrile seizures. Typical or simple febrile convulsion has 5 characteristics. First, the age is around 6 months to 5 years of age. It is generalized tonic-clonic seizures, not focal, and it is single during the same febrile illness. The child will develop only a single attack of convulsion during the febrile illness. The duration is not longer than 10 minutes, and the child is developmentally normal child. If we do EEG, it will be normal, but usually EEG is not required in children with simple febrile seizures. On the contrary, atypical or complex febrile seizure could be either focal or could be repeated during the same febrile illness, and the duration of the seizure may be longer than 15 minutes. Any of these features will suggest that the febrile seizures are complex or atypical and not simple febrile seizure. Children with febrile seizures are at a risk of developing epilepsy if they have a typical febrile seizure or a positive family history of epilepsy, or if they develop febrile seizure before the age of 9 months or after the age of 5 years, if they have developmental delay or abnormal neurological examination. Children with abnormal neurological examination or developmental delay, for example, children with intellectual disability or cerebral palsy, if they develop a convulsion in association with fever, usually it's not febrile seizure, it is usually epilepsy. Abnormal EEG in between the attack. After control of seizure, detailed history should be taken from the parents, including the immunization and vaccination history, history of previous attack of seizure, or history of epilepsy or family history of febrile seizure, epilepsy, or other neurological disease. Detailed examination to identify the source of infection and to exclude intracranial infection is also needed. Lumbar puncture should be performed if the child has any symptoms or signs to suggest CNS infection, for example, positive meningeal irritation or disturbed conscious level. Diagnostic workup. The diagnosis of febrile seizure is clinical. It is important to exclude intracranial infection in children presenting with acute onset of seizure and high-grade fever, particularly in complex febrile seizures. EEG is not required in a healthy child with febrile seizure and a clear source of infection. CT brain, MRI, and EEG are needed only if the children present with complex febrile seizure, recurrent febrile seizure, or have an abnormal neurological examination in order to rule out the presence of neurological cause. 1/3 of children with febrile seizure may experience recurrence of the seizure in association with high-grade fever. In order to prevent recurrence of febrile seizure, diazepam can be given orally. Intermittent oral diazepam can be given during the febrile illness until the patient is febrile. However, intermittent oral diazepam prophylaxis is not routinely recommended for all children with febrile seizure. Family anxiety, history of previous febrile status epilepticus, or recurrent febrile seizures and risk factor for recurrence are the main indication for giving intermittent oral diazepam to prevent recurrence of febrile seizure. Long-term treatment with valproate or phenobarbital are effective for preventing recurrence of febrile seizures. However, the adverse effect of long-term anti-epileptic drugs outweighs the risk associated with recurrence of febrile seizures. And it's not recommended to use long-term anti-epileptic medication to prevent recurrence of febrile seizures. Management of febrile convulsions. Diazepam is given slowly intravenously to control the convulsion. Diazepam can be given rectally if there is no intravenous line. Lowering of the body temperature is important by giving tepid sponges and antipyretic. Treating the cause of fever is important, and excluding intracranial infection is also important in any child presenting with a convulsion and fever. Discuss management of the patient. If seizure continue for 5 minutes or more, intravenous diazepam or midazolam should be given slowly intravenously to control the seizure. Lowering of the body temperature, and after control of the seizure, detailed history and examination to diagnose the cause of fever and to exclude intracranial infection. After diagnosis of the child as being febrile seizure, we should counsel the parent about the risk of recurrence and how to provide the first aid during the seizure and how to manage the febrile illness. And also we should determine the risk factor for development of epilepsy. If the child had low risk factor for development of epilepsy, intermittent oral diazepam is only required during the febrile illness in children with a family anxiety for the occurrence of seizure. If the child had a high risk for development of epilepsy, we should ask for EEG and MRI brain, and later on the management depends upon the finding of EEG and MRI.